Good afternoon, and thank you for joining the Alabama Coordinated Health Network's Changes to the Cost Effectiveness Bonus Calculation Methodology webinar. My name is Summer Macias with the Alabama Medicaid Agency. Before we get started, I have some housekeeping items to go over. First, all participants have been placed on mute. Please do not unmute your phones or microphones during the presentation to avoid disrupting the presenter. Second, we ask that all participants enter their name through the chat box function for attendance purposes. You may enter questions or comments in the chat box at any time, and we will answer questions after the presentation. If you have joined us by phone only, please submit your name and organization to achn@medicaid.alabama.gov. You may also submit any questions regarding today's presentation to achn@medicaid.alabama.gov. Our presenters for today are Director of the Alabama Medicaid Analytics Division, Kumari Sitala, and Managing Director with the Institute of Data and Analytics at the University of Alabama, Courtney Hanson. So I will now turn it over to Courtney and Kumari.
Hey, good afternoon, everybody. Thank you for joining us for this webinar today. We'll go over today we'll review the PCP payment structures and timelines. We will also review the cost effectiveness methodology, and we will go over the updates to the cost effectiveness methodology, and finally we'll take the question and answers regarding the cost effectiveness methodology. This is the PCP payment structure that you are all familiar with. The bonus payment is a $15 million pool that is funded towards the cost effectiveness, quality measures, and PCMH recognition to the providers on an annual basis. The bonus payments are paid quarterly, and PCP groups participating with the ACHNs are eligible to receive the bonus payment based on their performance with the quality measures, cost effectiveness, and PCMH participation. All these bonuses are distributed based on the attribution of the providers. This is the PCP bonus payment timeline. PCP bonus payment started in October of 2019. The first calculated bonus payment for cost effectiveness was paid in January of 2021. The cost effectiveness bonuses are calculated utilizing the previous 12 months of claims data with 3 months claims runout period. The first quality measure bonus payments were paid in October of 2021 using the calendar year 2020 quality measure performance. The guiding principles for cost effectiveness, consistency with ACHN's principles of paying per activity with a focus on preventative care and health outcomes, acknowledgement that the risk levels vary across practices. That means the sick patients are accounted for their expensive sick recipients as well as the expensive recipients are accounted in this methodology. Results are risk adjusted using validated methodologies. Evaluation of activities are done at the group level, consistently reviewed and revised when necessary to ensure all the costs are appropriately risk adjusted and methodology is consistent with other payers' practices. We'll go over the cost effectiveness overview. All participating PCP groups will be eligible for a performance payment if the PCP groups meets or exceeds the cost effectiveness criteria established by Medicaid. Medicaid utilizes software developed by MARA, Milliman Advanced Risk Adjusters, to determine risk scores for each individual Medicaid recipient. Several statistical models are employed for these processes. Risk scores are standardized metrics used to evaluate a member's previous health experience and are to predict health outcomes. Until this point in the ACHN program, PCP groups must have a score less than or equal to the statewide median cost effectiveness score to qualify for the cost effectiveness bonuses. And please note that the cost effectiveness calculations do exclude certain costs such as network entity costs, case management costs, other bonus payments, waiver costs, and drug rebates, etc. Now I will give it to Courtney. She will go over the cost effectiveness methodology as well as the adjustments made to the cost effectiveness methodology.
Thanks, Kamari. And so we're going to start with just a review of all of the equations used for the cost effectiveness calculations. And I do want to remind you that all of these equations are on the FAQ document that's on the ACHN website, on the Medicaid website. And so we first start by calculating your practice risk score, and this is just an average of the normalized individual risk scores. This is where we use MARA risk scores, the Milliman Advanced Risk Adjusters, to risk score every single individual that is attributed to your group. And then our second step is to calculate the actual per member per month of the provider group. This is done by counting up, by adding or summing the total amount paid for each individual, and then dividing it by the total member months for each individual in your attributed group. We then calculate the ACHN statewide PMPM, and so this is where we once again sum up total amount paid and divide it by member months, and this is for every Medicaid individual that is in or eligible for the ACHN, whether or not they are attributed. So we have some non-attributed folks that are in this PMPM calculation. We then use that statewide PMPM to calculate the provider group's expected PMPM. So we multiply the practice risk score that we calculated in step 1, and we multiply it by the ACHN statewide PMPM. And just a reminder, this is expected. This is given somebody's clinical profile, what you would expect somebody to cost. And then from there, we calculate the provider group's cost effectiveness score by taking their group actual PMPM, which was calculated in step 2, and dividing it by the group expected PMPM, which is calculated in step 4. All right, and so in the past, I just want to review real quick some of the cost effectiveness adjustments that we've made in the past. And a big part of this has been having the conversations with the providers and our multiple calls and hearing what it looks like in your practices and like how that translates into data. So for example, we've excluded inpatient psychiatry costs that are mostly covered by Alabama Department of Mental Health. This is a really good example of where we thought that MARA would risk adjust it properly, but because of the way that Alabama, the state, and Alabama Medicaid and Alabama Department of Mental Health pays for those claims, we're not capturing the full clinical detail. So we excluded those. We also started including Medicare claims in the MARA input data set, and that was to get a better picture of the clinical experience of the patient. And then we also are including as many as 40 diagnoses in the MARA input data set, where we previously only included top 7. Most commonly, 12 are being put in because that's the max on the provider claims. So as we took in suggestions from different participants in the ACHN, both the university and the analytics team have been analyzing many different scenarios to help improve the cost effectiveness methodology. And so we've been attempting to do so within the way that we calculate cost effectiveness and also the cutoff point of who receives the bonus and how that pool is distributed. So beginning April 2022, so the very next quarterly bonus payment, we will make the following adjustments to the process. So first, in order to exclude some outliers, we're going to remove the recipients with a total cost of $250,000 or more from the statewide PMPM calculations and the individual provider PMPM calculations. And then once we calculate your cost effectiveness score with these new PMPMs, the cost effectiveness score cutoff will be 1 or under 1 and not the median anymore. So to talk through the outlier adjustments and to start talking about the $250,000 cutoff, the patients that have $250,000 or more in your attributed group will still be in your attributed group, but just be removed from the PMPM calculations. So some reasons that we've started to do this is because it is consistent with what Milliman has told us, with what Blue Cross Blue Shield of Alabama is also doing in their payments. And there's also national risk adjustment standards that say that this is a good method to adjust cost effectiveness. I do want to point out here that there have been some assumptions made and that sometimes we are removing patients that are adequately risk adjusted. So their MARA risk score was fully accounting for all of these costs. However, we still thought it was an important move to make, change to make. So the results of this, so we've been modeling this on all of the previous bonus quarters, but most importantly on the last 3 quarters. And there's an average of 0.04% of the ACHN recipients are removed from the statewide PMPM. So about 200 recipients per quarter. This statewide PMPM also changes by an average of negative 7.83%. So a state PMPM that would have previously been around $250 will now be $230. So that's something that you'll definitely be seeing in your reports, is a lower state PMPM. And I think y'all know this because y'all have been bringing it up to us, but I did want to point out that the clinical profiles of these patients often contain NICU stays, cystic fibrosis, hemophilia, transplants, and other rare diseases. And the more important thing here is to notice that there will be that not everybody, not all of the patients are necessarily going to be always in that outlier group and taken out. Sometimes it's an acute situation, and then will be put back into your PMPM calculation. And then to talk about the change in the cutoff, we felt this was a choice to make because it is more inclusive to providers that are meeting the benchmark of the provider PMPM is less than the expected PMPM. This means that the providers that are receiving a bonus are being rewarded for being cost effective, not just being in the lowest 50% of cost effectiveness. But the cost effectiveness bonus is still a pool and since we are going to be distributing it to more groups, it will have less money per provider group. And so there's going to be an estimated 26% increase in the number of provider groups that will receive a bonus payment. So we're going from about 250 providers receiving one every quarter up to 350 to 400 providers receiving a bonus every quarter. So that means that providers that have previously received a bonus can expect a decrease in the amount of their cost effectiveness bonus payment. And we wanted to just show what some of the outcomes are. So I've talked about them separately, but this comparison and this analysis shows the averages across of applying both of these changes to the past 3 bonus periods. And so we are showing in the left, we're showing we broke out the practice group size according to attributed recipients. And the old scenario is what y'all have been experiencing for the last 3 quarters, and the new scenario is where we modeled it, where we remove those that are higher than 200, have costs higher than $250,000, and we changed the cutoff point to 1. And so you can see that this change will greatly impact the larger practices. And then we did break it out by region. This is where the practice is located. And so just for your reference.
I think that concludes our presentation for today. If you all have any questions, please feel free to put in the chat box or start asking the questions.
Thank you so much. So as Kumari said, we will now take attendance for those of you on the call today. If you've joined the webinar from your computer, please make sure to type your name into the chat box. And if you've joined us by phone only, please submit your name and organization to ACHN@medicaid.alabama.gov. Once again, I would like to thank Kumari and Courtney for the presentation. And at this time, we'll begin the questions and comment segment. And we will only be taking questions regarding today's presentation. So if you have any questions regarding the ACHN program, you can email achn@medicaid.alabama.gov. So thank you all for your patience. Courtney and Kumari, you can now take questions if there are any in the chat box.
I think that we've had a question about whether or not this $250,000 includes the inpatient psych hospitalizations. So we are still removing the fund codes and the costs that we have been previously removing up until this point. I think like in previous presentations, we've talked about how we're removing waiver costs, we're removing ACHN case management costs, and then to those costs that we've removed, we're also removing these inpatient site claims. Those will also still continue to be removed.
We're going to allow just a couple more minutes for anyone who may have a question to enter it into the chat box, and then we're going to move on, but just a couple more minutes for you guys.
We just had a question from Talisa Hatcher, which is, why is the ACHN program offered to specialists, not just primary care providers? I would just remind everyone that these are participating primary care groups that are eligible for this bonus. So again, if you have signed an agreement as a primary care group with the agency, with the ACHN, you are therefore eligible for this bonus. I hope that answers that question. We just had another question. Is there a way for individual practices to determine if they would have received a bonus had the new methodology been in place in prior quarters? Had this methodology been in place in prior quarters, if you had a score below 1, then potentially you would have been eligible for a bonus payment. But again, these changes were recently made as a result of several iterations running different scenarios with University of Alabama and based on provider feedback. So this goes into effect for your April payment and will be the new payment methodology going forward.
Thank you, Barry. All right, everyone, thank you again for your attendance today, and thank you to our presenters, Kamari and Courtney. This recording, along with the PowerPoint presentation, will be posted to our website and will also be available under the ACHN Providers tab. We have just one more question.
We have another question. Please review what determines a recipient's risk score. Courtney, do you want to take that?
Sure. So we take all the claims data set that is input into the cost calculation, and we put it into the MARA risk adjustment software, and MARA risk adjusters spits out a number. And then we normalize that number to the ACHN population for each individual recipient, and then average those out for your practice risk score.
Okay. Another question, are the degrees of sickness in comparison to cohorts still in effect?
Yes. So we are still, and that is by risk adjusting each individual. And so your practice risk score is what's adjusting for the varying levels of sickness.
We do have one more question relative to behavioral care offices in the ACHN network. If they do not provide EPSDT screening or primary care, how do they qualify? Again, if there is an agreement in place with the ACHN and the agency to provide primary care services, that's how a group qualifies for the bonuses. There is information on the ACHN website. And Travis Hauser, who is our director for the provider assistance unit. Travis, can you maybe provide a little more detail for that question? Travis is on and not muted. In Summer, can you also remind the participants the email address where I believe Ms. Hatcher asked this question? She can email that question specifically relative to participation agreements to the provider assistance unit. Can you please repeat the email information?
Hey, Barry, thanks. Hey, Barry, thank you for that. Ms. Hatcher, if you would email the ACHN inbox, and I can speak with you directly with your question. I would need some more details in order to accurately answer your question.
And we have a question from Ms. Thompson. Please let the PCPs know when the slides and recording will be available. Summer, will you be able to provide that information?
Hey, yeah. So the recording along with the PowerPoint presentation will be posted to our website, and it will be available under the ACHN Providers tab. Again, that's on the Medicaid website. They can just go there, look under ACHN, and it'll say ACHN Providers, and this whole presentation along with the PowerPoint will be available. And to answer your other question, they can submit questions if they've only gone by phone, then they can submit those questions to achn@medicaid.alabama.gov. Okay, if there are no more questions, we'll go ahead and close out today's presentation. Again, I want to thank everyone for your attendance today, and thank you so much to our presenters, both Kamari and Courtney. As I said earlier, this will be available, the PowerPoint presentation, the audio, everything on our website. So this concludes today's webinar, everybody, and have a great afternoon.